CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Under the mentorship of Dr. Jim Christensen. He is a Michael Smith Foundation for Health Research health professional investigator for looking at opiate overdose and cardiac arrest. He is also a professor in the Department of Emergency Medicine in resuscitation. He's authored 84 publications and 58 conference abstracts with first or senior authorship in more than half of those. He is published in JAMA, Circulation, Annals of Emergency Medicine, and Resuscitation as first author. These publications have been highlighted in JAMA editorials, Resuscitation editorials, and more prominently also in the New England NEGM Journal Watch. He has been the recipient of over $6 million in peer-reviewed competitive grants, with nearly half of that as a principal investigator. He is a co-leader with Jim Christensen in the CANROC, Canadian Resuscitation Outcomes Consortium, which is a national consortium of Canadian universities investigating cardiac arrests. He supervises multiple PhD and postdoctoral students in resuscitation research and chairs the British Columbia wing of CANROC. This is going to be a very interesting and very informative paper that it will change practice. So I'm going to let Dr. Grunau take it away. If you have any comments, please list them in the chat now. We'll attempt to moderate them. Thank you.
Thanks, Frank, for that kind introduction. I hope to live up to the interest of this talk, but you'll be the judge. Thanks for the opportunity to present here today at CHÉOS Rounds. I wanted to give an upfront shout out to all my partners who contributed to the project that I'm going to share about today, especially Jim Christensen, who I believe is in the virtual audience here. So in terms of disclosures, I have received speaking honoraria from Stryker Corp. And as Frank mentioned, I'm funded by the Michael Smith Foundation for Health Research. And one additional disclaimer about this talk, some of the audience today may be world-renowned statisticians with not so much clinical knowledge. Some are seasoned clinicians with little statistical knowledge, and others may be in the middle. So please bear with me as I review some of the concepts of both the statistical and clinical type in this talk. So with that in mind, here's a brief primer on the framework of out-of-hospital cardiac arrest. First, someone falls over in the community and hopefully a bystander initiates CPR. In any case, someone calls 911, paramedics zoom to the scene. In BC, this happens in a median response time of about 6.5 minutes. And then paramedics start CPR. So historically, paramedics would simply load the patient into the ambulance while continuing CPR and transport to hospital for ongoing care, while CPR is ongoing in the back of the moving ambulance. However, for the last several decades, training and competency of those operating in the pre-hospital space has increased dramatically. Paramedics now implement virtually all treatments at the scene of the cardiac arrest that hospital teams would provide in the emergency department for these cardiac arrest patients. This ranges from defibrillation to advanced medications. And this brings us to our controversial question about what paramedics should do after they have implemented initial on-scene therapies. Should they transport the patient to hospital, or should they continue treatments on scene? I thought I'd first deal with a few definitions that I'll be using throughout the talk that you might not be familiar with. First, out-of-hospital cardiac arrest refers to an individual in the community whose heart unfortunately stops unexpectedly. This is also referred to as a sudden or unexpected death. Next, ROSC, which is return of spontaneous circulation, which means that the medical team was successful at quote unquote restarting the heart and the patient has regained a palpable pulse. I will also be using the term intra-arrest transport, which refers to the procedure of paramedics transporting a patient with cardiac arrest to hospital with ongoing CPR. So let's talk about a quick case example. Paramedics arrive at a cardiac arrest at the side of the road. The patient's 52 years old and was previously healthy. The arrest was unwitnessed by bystanders. However, people soon found the individual down and started performing CPR. Paramedics assume control of the resuscitation and deliver 2 shocks for ventricular fibrillation. And the next rhythm is a non-shockable rhythm called PEA. They question, what should they do next? Should these paramedics continue to treat the patient for the full resuscitative effort at the scene, for example, for the next 30 to 40 minutes? Or should they package and extricate the patient and transport to hospital with ongoing resuscitation? Or perhaps this answer is somewhere in the middle of these 2 options. And this seems like a simple question, but it actually is something that bears to cardiac arrest resuscitations every day and is very controversial. So what's the scope of this clinical question? Well, extrapolating North American incidence data, pre-hospital professionals likely treat about 4 million cardiac arrests per year globally. We know that about 1/3 of these are able to be resuscitated. That is, paramedics can achieve a pulse and transport to hospital within the first 10 minutes or so of resuscitation. That leaves about 3 million per year for whom we need to address the clinical question that's before us. So what are we currently doing in clinical care? And the answer to that question is highly variable. This was one excellent study performed by Dana Zive from the Oregon Cardiac Arrest Research Unit, which examined North American cardiac arrest cases and reported the proportion of cases that were transported to hospital with ongoing CPR, i.e. intra-arrest transport. They examined a total of 23,000 paramedic-treated cardiac arrests and found that in 4,500 of these, transport was initiated prior to CPR, prior to a pulse being achieved. You can see the high variability in practice between regions here, with the columns representing different states or provinces participating in the registry with respect to their intra-arrest transport practices. For some, like Region A on the left, you can see that nearly 85% of cardiac arrests were transported to hospital with ongoing CPR. For other sites, such as System F, this management strategy was reserved for only a very small minority. So what is the evidence base to inform treatment of this extremely common clinical question and query? This slide demonstrates the available clinical trial level evidence to inform our practice. This page is left intentionally blank. Well, what about observational studies? There are multiple observational studies actually, which describe the outcomes of patients who were and were not transported to hospital with ongoing CPR that try to provide insights into our clinical question. This is one such study as an example, which followed the outcomes of paramedic-treated out-of-hospital cardiac arrest cases. In this region, paramedics pursued a short period of resuscitation in the field and then transported to hospital with ongoing CPR if a pulse could not be achieved. You can see that 856 patients successfully had a pulse achieved in the pre-hospital setting. The remaining cases, 83%, were transported to hospital with ongoing CPR. You can see that the interval from when paramedics started resuscitation to the hospital arrival was a mean of 19 minutes, showing that this really was a process of rapid transport. Of those transported with ongoing CPR, you can see that 79 patients survived and over 4,000, the majority, ended up dying. The conclusion reads, 27.5% of out-of-hospital survivors were patients without a pulse gained in the field. And thus they conclude, we suggest that all treated out-of-hospital cardiac arrests should be transported to hospital. In this study, all patients without ROSC or who a pulse were not able to be achieved were transported to hospital. The assumption here in this conclusion is that if these cases were not transported to hospital, they would not have survived. However, I'm not sure that we can make that assumption with this data. For a patient who is unable to be resuscitated with initial on-scene efforts, there are other options than transport to hospital with ongoing CPR. First listed there, you can see, is to simply declare the patient dead. That's called termination of resuscitation. This is probably not the best option to achieve survivors, but an option nonetheless. In addition, paramedics can continue the resuscitation effort at the scene. In these 4,000 cases who were transported to hospital with ongoing CPR, if they had undergone continued on-scene efforts, what would their outcomes have been? It is unclear from this data. And this is just one of the many examples of observational data looking at transport practices and attempting to give conclusions and guidance to clinicians, but it demonstrates how hard it is to make any conclusions. So we're left with the clinical question. For patients with cardiac arrest refractory to initial paramedic-provided treatments, should paramedics transport the patient to hospital? And please note the definition for the duration of paramedic-provided treatments is left ambiguous, as the time of this decision may affect the potential benefit of this intervention. So let's briefly consider potential benefits of intra-arrest transport. Well, firstly, you get to see all us lovely emergency department staff. The rationale for intra-arrest transport is that the hospital-based care performed by physicians, nurses, and the rest of the emergency department team is superior to the pre-hospital based efforts. However, in reality, as I mentioned, the majority of cases will likely receive the very same algorithms of treatment that would have been performed in the pre-hospital setting, and in fact, that already were performed in the pre-hospital setting. While some indeed argue that ED resuscitations are of higher quality, this has not been proven, and I've even heard a paramedic or two argue the opposite. We will leave that debate for now. The ED may have certain resuscitation techniques that are not available in the pre-hospital setting, such as more invasive strategies such as ECMO or eCPR or angiography. However, these treatment strategies are reserved for all but a very small fraction of the out-of-hospital cardiac arrest population and are more or less still experimental in nature. So to briefly touch on potential harms of intra-arrest transport, these center on deficiencies in resuscitation quality during extrication and transport. This study examined 191 out-of-hospital cardiac arrests in Denmark and quantified the cumulative time in which CPR was paused during extrication. That's moving the patient from the scene of the cardiac arrest to the ambulance vehicle. Overall, the median hands-off time without CPR during these extrications was 224 seconds, demonstrating that one does pay a penalty in CPR quality during the extrication process. After extrication, we can look at the quality of CPR during the transport phase. This study reported 75 cases from Oslo comparing chest compression fraction, which is the time chest compressions were actually being performed as a percentage during the on-scene resuscitation to that during transport. And we can see that manual chest compression quality definitely suffered during the transport phase. Additional aspects of concern of intra-arrest transport is paramedic and public safety. Performing CPR while standing in the back of an ambulance, balancing through the city is a harrowing task and can lead to paramedic injuries. We know that these types of transports can lead to motor vehicle collisions with their own morbidity and mortality. The study you see here used National Paramedic Information System data to examine 19 million 911 responses, and they found that lights and siren transports were associated with an increased risk of crashes, especially during the patient transport phase. So based on these questions, we sought to perform a study using the Resuscitation Outcomes Consortium data. You might know about the ROC, as we refer to it, which has performed multiple clinical trials and consecutively identified out-of-hospital cardiac arrests from 10 large regions in North America for a cardiac arrest registry. I should note the ROC's funding partners here. So in terms of using this network, applying RCT methodology would definitely be the ideal method to evaluate intra-arrest transport. At a predefined time, patients who remained pulseless would be randomized to either transport to hospital or continued on-scene resuscitative efforts by paramedics. Patients in both arms would undergo the same duration of total attempts at resuscitation, and then outcomes at hospital discharge could be compared. However, this would be an expensive trial and could only comment on one time juncture of transport, whereas it is possible that benefit may vary depending on when transport is initiated. So instead, we attempted to design an observational study with a design that could mitigate biases inherent with this type of question. We all know the standard biases in observational analyses. However, there are two important biases to consider when examining a time-dependent question such as this. So the first is indication bias, and I'm going to walk you through it here. Those who are considered for intra-arrest transport have already failed initial resuscitative efforts, making it a marker of refractory arrest, which is obviously a poor prognostic indicator. If your heart stopped and your heart is stopped for a longer period, that's a bad thing. Imagine that we divided a cohort of out-of-hospital cardiac arrests into one group labeled on-scene resuscitation, which is on the left, which includes everyone who did not undergo intra-arrest transport. These cases had their full resuscitation performed at the scene until they either achieved a pulse or had resuscitation efforts terminated. The other group we will call intra-arrest transport on the right, including those who were transported with ongoing CPR. And let's just assume for this example that everyone in this group is transported at the same time. You can see the y-axis is resuscitation time, with the resuscitation progressing as we move down the screen. There's a continual accrual of patients achieving a pulse as paramedics are successful at reviving patients. In this comparison example, you can see that all of those who are resuscitated early sorry about that. You can see here that all of those who are resuscitated early, those in the box there, those who achieved a pulse due to early paramedic efforts, are classified into the on-scene resuscitation group. This would obviously bias the results towards this group. What we really want to do is compare these cases who are transported pulseless at this time point in the on-scene resuscitation group to cases who are also pulseless at the same time juncture in the on-scene resuscitation group. This is easy to say in this example in which all intra-arrest cases are theoretically transported at the same time. However, this is not the case in reality. The second major bias is prognostication bias, in which certain patients are chosen for longer resuscitated efforts based on a prediction of a favorable outcome. This bias favors intra-arrest transport, as those who are transported typically undergo much longer durations of resuscitation. Those who paramedics choose for intra-arrest transport are also those typically who they deem to have more favorable characteristics, cases for whom paramedics choose to quote unquote pull out all the stops. And I apologize that for this example, time is on the x-axis with the resuscitation progressing towards screen right. And I further apologize for the crude graphic design. I'm sure my 6-year-old would have been able to make a better diagram. So the top is the intra-arrest transport group, who undergo transport at, for example, 20 minutes. They have resuscitation continued while en route to hospital, and then further efforts in the emergency department. This allows for at least 40 additional minutes in which they are eligible to achieve a pulse. In comparison, those chosen for non-transport are typically terminated soon after. Rarely these resuscitations last longer than 30 minutes. This difference in resuscitation duration biases the analysis towards the intra-arrest transport arm. So without further ado, I'm going to go over the study that we actually performed. The objective was to determine whether intra-arrest transport compared with continued on-scene resuscitation was associated with survival to hospital discharge among patients experiencing out-of-hospital cardiac arrest. The exposure was intra-arrest transport, defined as you've heard earlier, as transport initiated prior to ROSC or a pulse being achieved in comparison to continued on-scene resuscitation. So during the study period, there were just under 60,000 paramedic treated out of hospital cardiac arrests in the study regions. We excluded those with missing data on the time of the start of the professional resuscitation or the time of ROSC or transport, if applicable. We also excluded those missing one or more variables required for adjustment, pediatric cases, those with do not resuscitate orders, or those transported prior to cardiac arrest, in addition to those missing outcome data. In the end, we had 44,000 cases in the analysis, of whom a quarter were treated with intra-arrest transport and the remaining treated with on-scene resuscitation until pulse was achieved or termination. So it's true that we used a propensity score in this analysis, which I will describe further later. Propensity scores are great and reviewers love them. However, there are several results of the boring old unadjusted simple descriptive type that I think are just as compelling. And here is the first one. This graph illustrates the survival statistics of each of the regional ROC study sites on the y-axis and the proportion of patients treated with intra-arrest transport on the x-axis. At the top left, you can see we have site A with a survival of nearly 20% and a practice pattern of using intra-arrest transport in less than 5% of cases. On the bottom screen right, we have site J with a survival of less than 5% and an intra-arrest transport rate of almost 65%. Then we have all the other sites in the middle. We did not perform a statistical tests on these data looking for correlation, but I think a pattern is pretty clear to see. These are the outcomes of the full 44,000 case study cohort. Not surprisingly, you can see that the on-scene resuscitation cases had higher survival, and this is most likely highly due to the biases that I mentioned earlier, especially that pertaining to indication bias. However, the reason I show you this now is to provide more information about the intra-arrest transport survivors. Remember that intra-arrest transport means that they left the scene prior to achieving a pulse. Of these 446 intra-arrest transport survivors, 59% actually achieved a pulse prior to hospital arrival. And you will remember the rationale for transporting these patients to hospital is that hospital-based care provides benefit. Thus, seeing that 2/3 of the survivors actually achieved ROSC prior to hospital arrival, this raises questions about the actual hospital-based contribution to these cases. If we would have classified patients based on pulse status at hospital arrival rather than at scene departure, our survival statistics in this group would have been much lower. So onto the fancy analysis. We can't quite take credit for this time-dependent propensity score match design that we implemented, which is definitely more complicated than my statistical brain can handle, as it has been described previously on those publications you can see. In addition, I need to give credit to our statisticians, Dr. Brian LaRoe and Noah Keim, who created the models for this analysis. So what did we actually do? So first, the linear component of a Cox proportional hazards model was used to generate propensity scores for the intra-arrest transport assignment. Covariates in this model included age, sex, public location, witnessed arrest, bystander CPR, the interval from the 911 call to paramedic arrival at scene, initial cardiac arrhythm, whether there was an obvious non-cardiac cause identified, the training level of paramedics at the scene, and then importantly, the treatment region. So patients were paired using a time-dependent nearest neighbor propensity score matching algorithm. And in this way, intra-arrest transport cases were matched to cases with the closest propensity score, provided those cases were still undergoing on-scene resuscitation and thus were at risk of intra-arrest transport. So just like I mentioned earlier, we took a patient who was transported at time X in the red box there, and matched that case to a patient with the same characteristics and was still in refractory arrest and undergoing on-scene resuscitation at that same time point. Keep in mind that in the matching, that the on-scene resuscitation case may have actually undergone intra-arrest transport later in the resuscitation. However, at that time point, they were still being treated with on-scene resuscitation and thus were eligible for matching. You can see the matching schematic here. We started with the 44,000 cases I mentioned earlier in the full eligible cohort. We took the intra-arrest transport cases first and found the best on-scene resuscitation cases to match them, resulting in 9,406 cases in a one-to-one match. However, we wanted to use up as many of our cases as we could, so we took the unmatched on-scene resuscitation cases and looked to see if we could match them with already paired intra-arrest transport cases. This resulted in some additional intra-arrest transport cases being matched. This resulted in some intra-arrest transport cases being matched to more than one on-scene resuscitation case. In total, then, we had nearly 28,000 cases in the propensity matched cohort. So here are the results of the matching. Ideally, sorry about the small font there. Ideally, in matched cohorts, there should be a standardized mean difference between groups of approximately less than 0.1. And unfortunately, we were not able to achieve this in all aspects, much to the chagrin of the reviewers of our manuscript. I won't get into it, but region of treatment was the strongest predictor of intra-arrest transport, and we required that matches to be within the same region. Thus, achieving balanced groups was very difficult. Let's look at the characteristics in which the matching was over the 0.1 value. We can see that the intra-arrest transport cases here were younger, were less likely to be in private locations, were more likely to be EMS paramedic witnessed, and were more likely to have initial shockable rhythms, all of which are favorable prognostic indicators. We also ran the full analysis on the one-to-one matched cohort. As you can see, these cases were matched first and thus they got closer matches in the propensity score caliper and thus were more closely aligned. One additional element worth bringing up here is the prognostication bias that we discussed earlier. While indication bias is dealt with using our methodology, prognostication bias introduced by different lengths of resuscitation is not addressed. Here you can see that the mean length of the pre-hospital resuscitation duration is 29 minutes in the intra-arrest transport group compared to only 23 minutes in the on-scene resuscitation group. And this is just the pre-hospital resuscitation. Cases treated with intra-arrest transport have additional resuscitation performed while en route to hospital. Here you can see the mean time intervals for the scene to hospital transport, which overall is about 10 minutes. Then these cases have additional resuscitation performed in the hospital. We don't have data outlining how long these efforts continued in hospital. However, even if it's 0 minutes, the mean difference is already 40 versus 22. So here we have the outcomes of our propensity matched group. You can see that hospital survival is higher in the on-scene resuscitation group. We also looked at favorable neurological outcomes, which also favors the on-scene resuscitation group. So using the matched set, we then fit a Poisson regression model in order to calculate risk ratios among the full cohort and predefined subgroups. If you're interested in a commentary on this methodology, I'd refer you to the reference on the screen here. You've already seen the results of the full cohort and the subgroup with neurological outcome data. And in addition, we examined the same question among subgroups that we viewed may be more or less likely to benefit from intra-arrest transport. Keep in mind that due to these multiple subgroup analyses, these must be viewed as a lower level of evidence. First, we looked at the paramedic level of training, which looked at groups classified as advanced level training or basic level life support training of paramedics. Results were consistent with the main analysis as the main study group. The basic life support paramedic group unfortunately only comprised about 2.5% of the study cohort, so we didn't have a lot of confidence in this result. We also looked at paramedic witnessed cases and those with initial shockable rhythms, all of whom were consistent with the main analysis. This is particularly relevant as these are the phenotypes for whom many in the medical community would consider most to benefit from hospital-based transport. We also looked at a subgroup of mechanical chest compression devices, which theoretically may mitigate the CPR quality deficits inherent with intra-arrest transport. However, unfortunately, this subgroup was also limited by a low number of cases, only 4.8%. And finally, we have time-based subgroups, which included cases based on time of matching within 5-minute intervals, starting from the beginning of the professional resuscitation. For the intra-arrest transport cases, this is the time they were transported. These data may be the most controversial aspect of our results, as you can see that the association between intra-arrest transport and outcomes is the strongest in the earliest time periods. And as we hit the 20 to 30 minute time frame, the association barely stays neutral. And in over 30-minute time frame, it favors intra-arrest transport. We also analyze results by study site. And as you can see, all sites are consistent with the main result, except for one site that only contributed 271 cases. So we performed several sensitivity analyses. We ran within the 1-to-1 match set, adjusted for site as a random effect, and also used multiple imputation for cases with missing data, all of which were consistent with the main analysis. So overall, our results showed that intra-arrest transport compared to continued on-scene resuscitation was associated with a lower probability of survival and favorable neurological function at hospital discharge. And this was despite baseline characteristics favoring the intra-arrest transport group, suggesting that paramedics select favorable patients for this intervention. In addition, these results are despite the intra-arrest cases undergoing about twice the length of attempted resuscitation. And finally, remember that over half of the intra-arrest transport survivors were actually resuscitated prior to hospital arrival. In terms of subgroups, as I mentioned, nearly all were consistent with the primary analysis. However, there were some that we had less confidence in due to the low sample size. And what to make of the time-based subgroups? It is possible that intra-arrest transport later in the resuscitative effort does confer benefit. However, biases introduced by systematically different lengths of resuscitative efforts are likely the strongest in these subgroups. Remember that for the on-scene resuscitation cases, the mean duration of treatment until termination was only 23 minutes. Thus, cases in the over 30-minute group are likely declared dead very soon after this time juncture. This is in contrast to those undergoing intra-arrest transport at this juncture, who would benefit from at least 10 more minutes of resuscitation and likely much longer. Further, even within the over 30-minute time-based epoch, 61% of survivors achieved ROSC prior to hospital arrival. We actually did perform a slightly different analysis initially, in which we tried to deal with the biases introduced by prognostication and differing resuscitation attempt durations. We excluded from each individual time-based group those who underwent termination of efforts within 10 minutes of the time point of interest. For example, for the 40 to 45-minute epoch, it included cases who were undergoing active resuscitation during that time span and were not terminated prior to 55 minutes. And you can see that results of these time-based analyses are slightly different and slightly more in favor of on-scene resuscitation. So the overall explanation for our study results, we know that for the majority of patients, medical management is the same in the pre-hospital and ED settings. So for the average patient, if hospital does not provide incremental benefit, then we only have the potential to worsen outcomes with CPR quality deficits during extrication and transport. So let's talk about the limitations. Firstly, this study examines the optimal treatment for the average patient. Overall, on average, intra-arrest transport is associated with worse outcomes. However, as you know, we were limited by variables that we had, such as age, witnessed arrest, bystander CPR, etc. These are the typical cardiac arrest variables we collect. Are there specific individual cases who may benefit from transport? It's possible. For example, a patient with a hemorrhage related to a cardiac arrest or other special circumstances. It is possible, however, unclear. Other limitations, as with all observational studies, our conclusions are limited to association. And as I mentioned earlier, small generalizability to basic life support paramedic equipped regions and those treated with mechanical CPR, in addition to those bound for invasive hospital-based procedures, may not be applicable to these findings. Finally, although our analysis included multiple imputation to address missing data, which resulted in consistent results, it is a limitation. So where do we need to go from here with regards to clinical protocols? Firstly, one thing that we learned from this data is that we need to disentangle the concepts of time to termination and intra-arrest transport. Our analysis attempted to isolate a change in resuscitation location, whether it's on scene or to the hospital, and can make no conclusions of the appropriate conditions or time to terminate resuscitation. And the diagram on the bottom shows how resuscitation phases are currently considered. We have step 1, in which paramedics attempt resuscitation at the scene, and that's in blue. Then they decide whether to transport to hospital or terminate in the field. Looking at it this way, it looks clear that if you terminate in the field, you are quote unquote giving up and not providing all available care to the patient. However, this fails to recognize important aspects of time, i.e. that the on-scene resuscitation effort can be very long or very short or different in these two examples. Instead, we need to look at it with two distinct and separate questions. How long am I going to continue resuscitation for? This should not be dependent on whether you are transporting to hospital or not. You can see in the example below that these two cases are now getting the same duration of resuscitation attempt overall. Then we have the second question. What is the optimal resuscitation location? Am I better to perform this full resuscitation effort on the scene, or should I transition my resuscitation to the ambulance and to the hospital? And according to our study, our data supports a strategy that paramedics dedicate effort and expertise at the scene of the cardiac arrest rather than prioritizing transport to hospital. Our data suggests that changes in protocols favoring on-scene efforts may be warranted for these reasons. And that's the conclusion of the talk. Thank you very much.